with this, may I invite Dr. Rajiv Raman sir for his talk on AI for diabetic retinopathy screening. Dr. Rajiv Raman sir.
Thanks, Dr. Subuddhi. Thanks, Chitranjan, organizing such a nice session. And I think my work has been made very easy by Dr. Kim. He has already explained how AI can be used for diabetic retinopathy screening. I'll answer few of the questions because now we know that AI is working. And let's see that what do the screening guidelines tell us about DR screening and use of AI? How I select an algorithm if I have to purchase one? How we address the problems of non-gradable images? Will the same algorithm work for even if I have a wide field photograph? Is the performance of algorithm dependent on a camera? Can we have some other strategy like a risk factor based screening? What are the current evidences? And lastly, just I'll touch something on generative AI and diabetic retinopathy. So let's answer these questions in next 8 to 10 minutes. So the first one, what the guidelines say. So in 2020 was first time American Diabetic Association included AI for DR screening as one of the part for standard of care for diabetes. And they went ahead saying that you can use it as an alternative to a traditional screening approach. And they also went ahead saying when not to use AI. They said that if a patient already has known retinopathy, if he is already undergoing some form of treatment, or if he has visual impairment, because these are the indication where ophthalmologists should see. It's not where AI will work at all. So that's something you don't need to use AI. All India Association and Vitreoretinal Society of India came out with a consensus statement, and in that too we have included AI for DR screening. However, because we don't have a legal framework, the use is, we said that anything which is graded as referable should be again seen by those images should be graded by ophthalmologist, and at least 10% of even normal should be seen by ophthalmologist. So that's the guideline which All India Association has given. And very recently, last month, actually we have hit the nail, because whatever we say, the screening has to be done by the physician because they are the first people who see diabetic. And now we have made a guideline with RSSDI. So VRSI and RSSDI guidelines for diabetic retinopathy screening has come, and it tells all these questions that how to select an AI algorithm, how you can use it, and what are the government reimbursements if you do a screening for physician. Now let's see how to select an algorithm for the use. So whenever you are looking, you get somebody says that I have an AI algorithm, it works very well. Try to see that what was his training set, on what basis he has created this algorithm, how was the ground truth ascertained, because majority of time as diabetic retinopathy we have seen even retina specialists can make mistakes. So whether it was 1 grader, 2 grader, like Google paper which we had 54 board certified ophthalmologists who graded the images. Whether the algorithm was trained using images which were captured through a mydriatic camera or a non-mydriatic camera. Because so ultimately it depends how you intend to use it. If you want to use it in a non-mydriatic mode and you use an algorithm which has been developed using a mydriatic image, on that performance they will say it works 98% well, 99% well, but when you really use it, the performance would be low. And whether it was trained using a single field versus multiple field. Like if you look the IDX, which is the first FDA approved, that was, the algorithm was not made on single field, but on 2 fields. And what we do in our clinical practice is single field. So there is no sense, even if IDX says that it is 99% accurate, you will not get that accuracy when you try to use it. So you select the algorithm depending on the circumstances of your intended screening, how you want to use it in your clinical practice. This was an interesting study which we did. We used a AI algorithm which was developed from Selena, that is Seri. It is inbuilt into a Zeiss camera, and though the Selena was developed using mydriatic images, we used it on a non-mydriatic image and saw whether the performance is good or bad. I'll not go into detail, but the sensitivity is pretty good, specificity reduces. However, nothing, in comparison with nothing, this definitely works. but not as good as an algorithm which is developed using a non-mydriatic image. How to address the problem of non-gradables, because this is the major chunk. Whenever you are using a non-mydriatic camera, about a third of the images would be non-gradable. And now there are AI algorithms which can detect whether an image is gradable or not. So this was a work which we had done in collaboration with a UK group, and we found that we can detect with a very high accuracy whether the image would be gradable or not. And if it is non-gradable, it can give a prompt to the photographer that you can retake the image so that we can get a better quality image. Will the same algorithm work if we use it in a ultra wide field image? People have tried. So AIOC is a company who made initial with a single small photograph and used that algorithm for ultra wide field imaging, and they were fairly successful. However, this was one of the work which we had done with Dr. Carol Chung, and we have developed the algorithm for wide field imaging, which is very fairly accurate to detect the lesions and classifying diabetic retinopathy. Is the performance of the algorithm dependent on camera? And this we could do because the Google AI was used extensively in Thailand, which had nearly 600 cameras and all different brands. So we saw that, is it comparable, all camera, is there any difference between them? And what we found that if the image is gradable, the performance of AI seems to be similar. If it is non-gradable image, definitely it is, but for a gradable image, a good algorithm will work across the cameras. Can we do something on risk factors? Because we cannot screen 101 million people with diabetes in our country. If we say that you need to take a dilated or you take a retinal image for everybody, next to impossible. So definitely we need alternative approach, and one of the alternative approaches that can we identify only a high risk group and do a retinal screening for them. And this was actually, we used all the available population based data. So this was from Arvind Eye Institute, from MV Diabetes, from Shankar Nethralaya, all population based studies used that data which had all the risk factors and created algorithms. So I'm not going in detail with the steps how we created it. We used something which people use in gaming called as Shapley methods, and even t-tests. We ranked these risk factors and came up with an algorithm that just without retinal image, if you feed in these risk factors, accuracy AUC of 0.8, we could say whether a person will have retinopathy or not. So probably a sequential, first a risk factor based screening, and if you are positive, take a retinal image is an answer for a country like India. Lastly, just touching that about generative AI. So today that is the buzzword, and AI is going in, more and more work on generative AI is happening. And this is a very recent work which we have published, work which was spearheaded by Dr. Tin Wong, and we were part of it, lucky to be part of this study, where they tried looking at, can we use a deep learning system for predicting the time for progression? That becomes important. So this algorithm, you put the image and it will say that in next 4 years, whether a person will progress to a high risk of progression or a low risk of progression to a sight-threatening disease. It was tested across nearly 7 populations across the world, all of them showing a good accuracies, and that has included generative AI also into it, which can give a prompt. So not only the diagnosis, but it also gives what to be done. So it's a text report which comes that you need to, laser is needed, anti-VEGF is needed. Now you can just relax and come again after 3 months. And what we found in our Ascend Dreams data set, by using this algorithm, we routinely tell our patients that you come for a follow-up every year. And by dividing using this AI algorithm, high risk and low risk of progression, we could extend the follow-up to average 31 or 32 months. Now that's a big thing, because you don't ask them to come every year. They're coming 32, the overall load for diabetics to be screened reduces. And this also reduced the frequency of screening to about 62%, and the model had only 0.37% rate of delayed detection. Rest all it could pick up very well. So this is something which we will see in future. Our load, so though we have 101 million people of diabetes, we will have these strategies which can significantly reduce, so that we can do effective diabetic retinopathy screening. Thank you very much. questions, I'll be happy to answer.
Thank you, Dr. Rajiv Raman, sir, for the excellent talk. I have one small question, sir. That Thailand study with Dr. Python and all, you told that different cameras you use. All of them were handheld camera of different company or
No,
tabletop
not
camera?
handheld. They were table. So
Tabletop
they were
camera.
Topcon. They were majority were tabletop.
And
Canon
not
was the only handheld tag. Though they didn't had Remedio and others which we have in India. So Canon was the only handheld camera which was, but that also performance was reasonably well.
so there was no significant difference.
No difference. So that's what I told. If an image is gradable,
Yes, sir.
gradability changed across the cameras.
Yes.
So there are certain cameras which are, we know that tabletop cameras will have better, patient cooperation, your skill required is less, so more chances of getting a gradable image.
Yes.
But if it is a non-gradability may change between the cameras.
Yes, sir.
But if it is a gradable image, the AI performance is same.
Okay, sir. Thank you, sir. Any questions for Dr. Rajiv, sir? Okay.
Thank you.
Any comment from the panel? Any questions?
It was a really amazing talk, Dr. Rajiv, because in diabetes, the early detection and the treatment and monitoring the progress is the most important thing. It can really reduce the overload of diabetic screening once the AI has come up. So we have a great future. Thank you so much.
Thank you.
Thank you very much.